Hello and welcome to this edition of Ask Your Doctor. I'm Dr. Alan Thornhill. I've been working in the field of IVF for over 25 years in a variety of different roles, starting as a clinical embryologist in the lab and now providing support and guidance for patients as a fertility coach. This evening, I'll be your host for what's going to be an interesting and important session covering what is probably one of the most frequently asked questions. How many cycles do I need for a successful pregnancy? This is a fundamental question for a number of reasons. It touches on many areas, including the cause of your infertility, your reproductive history with or without treatment, your finances, and your emotional and physical capacity to go through multiple rounds of IVF. I'm joined tonight by a fantastic set of panelists who are here to help you better understand how many cycles do I need for a successful pregnancy. They are Dr. Miguel Ángel Checa, Medical Director of Fertty, Spain, Dr. Violeta Fodina, Medical Director of IVF Riga in Latvia, and Professor Ana Santos, Administrator and Scientific Coordinator at Eugin, Portugal. Now, I'm going to start by asking each of our panelists to answer one of three fundamental questions, just to provide a brief introduction to tonight's topic, and then we'll answer your audience questions. Okay, they're also going to introduce themselves and their clinic as we do that. Now, I'm hoping we can cover what you want to find out, what the clinic can do, and what the relative importance of each is going to be. If I can ask you to please put your questions in the Q&A box rather than the comment chat, that will help us to deal with them. Otherwise, I'm flipping between lots of different boxes. We will try to answer all the questions, but I will be prioritizing ones that are easy to generalize, haven't already been answered, and stick to tonight's topic, okay, just in the interest of time. So, we're going to start with Dr. Checa, Miguel, and I'm going to ask you this question, but please introduce yourself as well. What do we mean by a successful pregnancy? Because that's quite vague. So I want you just to talk about, what success actually means. All right. So over to you, and then we'll go to the other doctors. Thanks.
Thank you very much, Alan. Dr. Miguel Checa, you present me. I work in one of the founder of Fertty Clinic here in Barcelona. I'm professor of University Pompeu Fabra and director of the master degree of assisted reproduction of University Autonomous of Barcelona. We are published more than 100 papers, and we do lectures in Amsterdam and Israel during many, many years. And particularly me, I'm specialized in advanced maternal age and IVF and in egg donation. So what is a successful pregnancy? Successful pregnancy normally is when you have a positive result and finally you see a sac in the uterus and finally arrive a baby at home. Normally in our clinics, we follow these patients until we are at mid-pregnancy. More of our patients go outside of our country. But for us, successful pregnancy is when we see the evolution to 21 weeks, because this is part of the pregnancy. The other are complications of the pregnancy.
Okay, thank you. That's really good. And the reason I asked you to do that is because, as you know, doctors, health providers, and patients sometimes use the word pregnancy, and it can mean lots of different things, right? So that's why it's important to be on the same page for that. So thanks for that. Let's move on to Dr. Violeta. Your question is, what do we mean by an IVF cycle? And what I mean by that is, obviously, it's again one of these naming things where someone will say, oh, I had 3 cycles. And when you ask them more details, they say, I had 3 transfers, and it was only 1 stimulation cycle. So just to kind of, define that. And then, of course, please introduce yourself and your clinic and your specialty. Thank you.
Okay, hello, my name is Violeta Fodina. I'm doctor reproductologist and medical director of IVF Riga Holding. I am the PhD doctor of Latvian University and also the author of the 3 original papers, and one of them it's a failed implantation in IVF Riga, in IVF cycle, sorry. And the answer for your questions, of course, the IVF succeed. It is the results what we are getting after the embryo transfer. And the embryo transfer for the it might be the several time, and if to doing the 3 treatment more sexual and get the positive results, we needed to focus it for the most important examination what we can doing before embryo transfer. And our focusing in treatment of our difficult patients, and especially the patient with the failed implantation, focused for that. In the clinic, we have the 3 laboratories, which is the combine the activity for the help for one of the patient. This is the embryo laboratory, genetic laboratory, and the immunologic laboratory. And the specialist in all this field can combine their space if to decrease the chances for the pregnancy and getting the positive results.
Thank you. So let's move on. Last but not least, Dr. Santos. So remember to introduce yourself and your clinic, please. And your question is, what are some of the key elements that are likely to lead to a patient having more cycles versus fewer cycles? Thanks.
Hello, I'm Teresa Almeida Santos. I'm a professor in the University of Coimbra and responsible for Eugin, Coimbra, Portugal. We are a fertility clinic that is well known in Europe, but in Coimbra we are only since 1 year ago. But I have been doing reproductive medicine for 30 years now. And we have the particularity of doing a lot of egg donation with non-anonymous donors, which is not very common in Europe. So we are specialized in this type of treatments. So I think the most important determinant for the several IVF attempts is, of course, the age of the women, because it is the main influence on the quality of the eggs and the embryos. So nothing is more important than age. Indeed, age matters. Female age matters a lot. And that's why when we have several failed IVF cycles, even with own eggs, we must try to get the donation into discussion.
Perfect. Well, I led you nicely into my funnel to talk about age, because actually many of the questions from the participants tonight, so far at least, relate to age. Even though there's a lot of other information, they do relate to age. So let's move back to Dr. Checa. I mean, I'm going to give you all a chance to answer questions, and if you do have anything to add that's different, please put your hand up or wave at me, or put in the chat, and I'll get you to add something to it. So, Dr. Checa, here's our first question today. And it says, how many IVF cycles, so it's absolutely on topic, how many IVF cycles would you advise for a 45-year-old woman? This particular patient's already had 3 ICSI procedures using frozen eggs between the ages of 37 and 38, but failed implantation. So it gets into more detail, what protocol and everything else, but let's just stick with the 45 that we've already had some failed cycles. So can you comment on that and then generalize, please?
As Dr. Almeida says, age is the most important determinator from the success rate in IVF. No, we always work when we pass 37 years old, always with PGTM. Why? Because it's the reason that we need to transfer a healthy embryo. Try to do failed attempts, or try to do attempts that gonna be a miscarriage. Don't have a space in our clinic. No. So for a woman of 45 years in my clinic, if we do 3 attempts without a pregnancy, probably next step, most of the common cases, going to be to perform an egg donation. Normally, in 3 IVF attempts in 45 years old, if we don't have the pregnancy, the best way is try to change to an egg donation.
Okay, thank you. Do any of the doctors have a different opinion on that? Or are we pretty much agreed on that?
We agree.
Okay.
Mm-hmm.
Okay, thank you. And just for the audience's sake and knowledge, if you go back and scroll through some of the previous Ask Your Doctor sessions, we have covered things like age. We have covered things like if you've got low ovarian reserve, which obviously comes with age. Are there any special protocols you can do and things like that? So I think that would be useful to go back to those if you want those specific bits of the question answered. Next question is from a lady who unfortunately can't join us tonight. There's a lot of information, but I'm going to sort of summarize just from her first paragraph, actually, which says, what are the chances to succeed if we already have transferred 10 blastocysts, 4 of which were PGTA tested, and I presume that means euploid or normal, and 6 untested but good quality embryos? So I'm going to give that one to Dr. Fodina, please.
The answer for these questions, of course, we understand that the pregnancy results depend not only for the embryo quality. Of course, it is a big revolution as we can test the embryos before embryo transfer now. We are happy about it. But the results, of course, it's compared also with the different factors. One of them, it's a uterus status, how the good they are for the implantation. The second one, it is a different factors from the mama's body. For example, coagulation options, the hormonal options, and immunologic options, which affected for that. And if this patient already had a so long experience with the unsuccessful treatment, I will be recommended to focusate it for that. So what really we can do? First of all, when we examine the uterus, of course it is a conversational question, so yes or no, but maybe we can do the testing of the endometrium for the implantation possibilities. It's included the time of the implantation, it's including the activity of endometrium, and of course the microbiome, which is one of the factors which can give unsuccessful results if they are positive. The second one, of course, we needed to excluding the hereditary and not hereditary coagulopathy as thrombophilia, homocystinemia, SC factors, and also the very rare factors as 8 factors and 9 factors of the blood. And one of the new, again, controversial options, but what we start to using more and more in our practice, this is the immunologic status of the patients. So very soon I plan to publish the paper about the lead procedure. We are collecting enough experience in these questions. This is injection of the CD cells from the partner to partner for the immunization and increasing of the chances to get a pregnancy. So following the magazines, medical magazines, and probably you can have a possibility to read that very soon.
Thank you. Thanks for that. That was a very comprehensive answer, and you covered, in fact, lots of the elements that the patient had mentioned. So it sounds like she has had quite a comprehensive workup in the past. It doesn't specify whether she's had endometrial tests, but it does talk about the endometrium. So thank you for that. And certainly with a history as complex and as long as that, it's definitely worth shopping around, speaking to lots of different doctors and seeing what they would do. But I think the message about the age and the number of attempts is quite critical, obviously. So, Dr. Santos, we're going to move on to you now. This is an interesting one. This is a patient who will be 53 years old in October. They've had a son before, had a child before who's 24 now, presumably with their own eggs, and they want to try egg donation. Their overall health is good. Let's start with the second part of the question, because the first one is about where could I go without spending too much money? And, that's a kind of loaded question, and it depends. But there's some good resources out there to look at, good places to go to get a cost-effective treatment. All I would say, though, is make sure you're comparing apples and apples. That's the most important thing. But the medical question here is, what should I do in advance for preparation for egg donation? So what are the sort of things that this lady should be thinking about?
We are talking of a lady of 53. That's it?
Correct.
So the first thing that I will tell is that in Portugal is not allowed to do IVF over 50. And this has a reason, of course. It's because of the risks of pregnancies in women over 50. So this patient must be aware of the higher risks of pregnancy in that age. Once she is aware of that, she must, of course, try to get a center in the country where it is allowed to do so, and where egg donation is done with quality, so that the donors are screened both for infections and also for genetic or more frequent genetic disease. This is what I would say to her, because the treatment is the same everywhere. I mean, IVF is not very different from one lab to another. So the main question would be the kind of gametes that she will use and the main risks of pregnancy at this age.
So thank you. That's really helpful. And thank you for, as I asked you all before the session, if there's some specific legal regulatory restriction in your country that relates to the question, please say so. So thanks for that. Let's pretend she's 49. So obviously we've talked about getting a suitable egg donor that's been screened and so on. What things would she, the recipient, have to do?
Of course, we will have to check if her uterus is okay, if there are no problems in the uterus, if the endometrium grows like it should grow, and if there are no other pathologies, I mean cardiac pathology or any heart pathology or other that would be dangerous for pregnancy. She should have, in Portugal, it would be mandatory to do a screening of heart diseases, and also a general checkup in order to see that everything is okay with her to get pregnant and not to get worse some hidden pathology that she may have.
Perfect. Thank you very much. That's a really helpful answer for her. Okay, so I'm gonna mix it up now. I'm gonna sort of change the order so we don't just go round in a circle. So this next question, I'm going to go to Dr. Fodina again here. So what are the chances for successful implantation and live birth for women over 40 from the first try?
My favorite question. So when I get the patients over of the 40, and we started discussing about the possible pregnancy, I usually started with one of the criteria what we are using every day during the taking of our patients. It's a Poseidon criteria. I explained for my patients the results of the treatment will be depend, first of all, of ovarian reserve, what we check through the Bologna criteria. This is the through points, very easy. MH, FSH, and AFC. And when we know how many eggs we can get it, we can recalculate the possible chances through the Poseidon criteria. And of course, the results, it's absolutely completely different of the patient in the 40 with the approximately 15 eggs after the retrieval and 2 eggs after the retrieval. So, and it's however, it's compared with the amount of the euploid embryos what we can wait from the woman after the 40. It was very interesting publication, Fertility, Sterility, when they show exactly how big percentage of the euploid embryos we can get it from the patients in different age. And the woman after the 40, they calculate 40, 41, 42, 43. So they started with the 20%. So that by logic, we understand if we are getting the 10 blastocysts, for example, the chances to get the normal embryo pretty high, the chances to get the pregnancy pretty high. But if we have the low response in this age, unfortunately, the percentage not so high. And I finalized maybe my answer with the average of the chances of the woman after the 40 to get the pregnancy. It is around 15-20%.
Okay, thank you. And in your previous answer, you nicely differentiated between focusing on egg and embryo quality and the endometrium, or the receptivity part, not specifically receptivity, but the endometrium. So this lady says she suffers from hypothyroidism. She's a factor V Leiden heterozygote, and she has C1 genotype. in common with her husband, and had a myomectomy 4 months ago with 6 fibroids removed. How is this going to change the picture for you?
I think that the patients examine very well, and if we know what is wrong, it's easy to pass these factors. So the factor number 5, Leiden mutation, this is a thrombophilia. It is nothing special. So we will be using the microhyperines, and we will be compensate these factors. If we speak about the KIR-AA, we are focused with these questions, and I 2 minutes can explain. So our previous strategy and tactic was compare also with the examination of the embryos for the HLA receptors. Now we are changing a different tactic to using the lead procedure for this patient, because the patient who have the KIR-AA, it is a hereditary changes in the NK killers. Unfortunately, they have a high risk for non-implantation, for the early miscarriages, and if we will be succeed anyway, we have a risk of the placenta insufficiency, which give the problems in the 3rd trimester of the pregnancy. So if we know these factors, for my opinion, these questions could be tried to decide it during the preparation time, and she's women have the same chances as the other woman after the 40. I will be focused more for the ovarian reserve and the possibility to get the euploid embryo.
Perfect. And just while I have you, could you just say very briefly whether there are any age restrictions for using your own eggs or donor egg in Latvia, please? Just very briefly.
So we have a law since 2006, very liberal law. You will be surprised, but in our law, we don't have a limitation of the age of the woman. But of course, we have some our own clinic rules, and I totally agree to my colleagues from the Portugal. I also very skeptic about the pregnancy after the 50. This gives a lot of risk for the woman during the pregnancy time, and the risk of the gestation diabetes, about the placenta abruptions, about the arterial hypertensions, and different kind of complication for the mom and for the future child. It is pretty high. So if we speak about the egg donation, so I answered for the question, but if we speak about the oven eggs, of course, we are trying to do the maximum what we can do, but we are not the gods, and we don't have the magic tablets what we can give and change the age of the egg. So my personal opinion, we needed to focus it for analyzing to the each patient before when we start the IVF treatment. And if we see the chances, it's pretty low, we needed to explain that for the patient and give the realistic pictures. So I hope I answer for the questions.
Yeah, sure. But yeah, okay, perfect. So now I'm going to move on to Dr. Checa, because we already heard from Dr. Santos about the age restrictions in Portugal. So I'm going to give you 2 questions back to back. The first one is, if you can answer the age one, the same thing. What's for your own eggs and what's for donor eggs, please? And then I'll ask another one.
In donor eggs in Spain, it is a recommendation of the law. It's not a law, that a general recommendation that we don't pass of 50 years.
Okay.
Our clinic is restricted in 50 years. Our ethics in my decision of all the clinicians is not past 50 years. In IVF, after several years practicing IVF, we don't obtain any pregnancy over 45 years old. So now we restrict the patients to perform IVF over 45 years old, because we don't have any pregnancy. So we are a serious clinic, and we don't give hope to the patients to do treatments that we don't have these results. Respecting the previous question about talking about KIR-AA, I want to do a transmission for all the patients. I don't want to scare the patients, because this is now, this last year, not now, because there are published many papers after that, that this mismatching, this is not an incompatibility. Okay, it's only a mismatching when you have AA or C2. This mismatching allows the pregnancy. It's not implantation failure. Only you have more increase of miscarriages, but more increase of preeclampsia. But there are many, many papers published, not for us, for the people that we do assisted reproduction, for people that do pregnancy, of thousands of deliveries of these children with high risk of hypertension, but deliveries. So before to start treatment, start with all of these determinations of immunology. I think it's not the good way, because we are over-treating, delaying the process of IVF in patients that don't have previous failures or previous miscarriages. So I think we need to be very serious, because no SRM, no ESRE recognize this kind of determinations to increase the pregnancy chances in our patients. It's like the determination of endometrial assay receptivity. We started many years ago practicing these tests for a lot of patients. I research with that. I publish paper with that. I'm a researcher, and I continue doing this kind of research. But try to use for all the population, it's not a good tool. Recently, we published with the first most cited scientist from Spain, not my clinic, IV clinic, Ginemed clinic, hospital clinic, all the big ones, all the researchers that we publish more papers, doing a recommendation that not try to generalize, because many times we are changing the things. Since 3 years ago, we pass in our clinics to a natural cycle when we perform transfer and transfer, and the chances of pregnancy are equal or superior to using hormonal replacement therapy. So it's very important that the people, all of these communications that go to the general population, all of these companies that try to commercialize this kind of test, go straight to the patient. And this is not good, because they don't have the knowledge to know if they could apply to particular case or not. So I think this kind of test may be restricted only for people that they have really problems like implantation failure, like more than 3 embryos. You know the results that when you have euploid embryos, my rates in all the ages you have euploid embryos, in 2 or 3 transfer, you almost arrive to 100%. It's 95%. 95% we arrive to this. It's not difficult. You have a good clinic with a good culture. It's important. It's very important, the type of culture. In different clinics you have different types of euploidy. It depends the culture. So if you have a good culture, you have a good rate of euploidy. In 2 transfers you are under 35, but in 3 transfers you are over 40. You could achieve a pregnancy, but you need to have euploid embryos. We are doing a lot of tests only for 5% of chances of pregnancy. 95% you could achieve with good embryos. So we need to focus in obtaining good embryos to achieve a pregnancy.
Okay, thank you. So I'm going to ask you this next one, and then I'm going to check with Dr. Santos whether it's relevant to her as well. This question is, I'm just going to make sure I'm at the top. You all seem to be in favor of PGT-A. I don't think you've all said that so far, but I think there's a general comment. A lot of clinics now offer PGT-A. I did this in my first round, age 43. I had 3 good grade day 6 embryos, blastocysts. PGT-A said they're all abnormal. Obviously, we need to know exactly what that means. What do you think about the body? I think she means the embryo's ability to self-correct. I'm now moving to Greece for my second cycle, where they don't favor PGT-A for women my age, but they prefer to put embryos back without testing when you have very few. So let's just, can we hear your thoughts, Dr. Checa, on that, please?
Yes, I agree that PGT-A is a good tool for women that have a high risk of aneuploidy, which is over 41, 42. But of course, we need to have enough embryos that achieve day 5 in order to be able to do PGTA. And the problem is that women over 41, 42 not very often have a lot of embryos. But if they have, I would counsel them to do PGTA because like that we can transfer the euploid embryos and not lose money, time, or lose the possibility of having pregnancy if we are just to choose the embryos by morphology. Even if we use time-lapse or to try to select the best morphologic and morphodynamic characteristics of the embryo, this is not enough at that age. So PGTA should be advisable. And as far as self-correction of the embryo is concerned, even if it has been described in papers, I don't think that is a real possibility that should be very wait for it. So if we are able to select the best euploid embryo, I think is the best we can do for the patient at that age.
Okay, great, thank you. So I don't want to put words in your mouth, but this patient said, "I'm going to Greece where they don't do it," and essentially the question is that, do you think that's the best approach? And I think your answer is no. I think PGTA, if you have embryos and everything else, is probably a better approach. Okay, thank you. So I'm just going to add something in here because I've got a bit of PhD experience myself. I would just say it's very easy to use the word abnormal, and it turns out it's quite important to be very clear about what that abnormality is. So the very sophisticated technology we've used for the last 10 years has sort of created a bit of a problem in a way. It's given us so much information, it's not always that clear. So all I would say about that is be clear about what the abnormality is, because certain abnormalities, I don't think there's any coming back from them. There's no self-correction. And other abnormalities, the question is it really an abnormality to begin with? So I'll leave it vague like that, but I'm just making a point that abnormality isn't equivalent to another abnormality, and we need to be clear about that. I'm going to ask the same question to Dr. Checa, though, because I'm pretty confident you probably offer PGTA, and I'm interested to know what you would do in this scenario, please.
So I don't have the question of the patient in my chat. So the scenario was, okay, so PGTA, first round, 43 good grade, and PGTA is normal.
So basically, they're saying we're now going to another country where they're probably not going to do PGTA. Is that a good idea, or should I be still doing PGTA?
I recommend. I told you after 37 years old, I recommend PGTA for all my patients.
Okay.
It's a decision to try to don't fail, to have a successful pregnancy as soon as possible. I know if we transfer all the embryos, finally we're going to find this embryo. But it's a really high cost, emotional cost, and economical cost for a patient to do a transfer of all of the embryos, no? And finally, if you have a PGTA like this woman of 43 years old, you could explain what is happening to the patient, no? You know what is happening. And if sometimes you have this problem of this doctor of where it could come. Normally it comes from the woman, but not 100%. There are patients that come from the men. Nowadays, we do an analysis that we could know the origin of the aneuploidy. If it comes from the daddy or from the mom. So if we have this problem one time or two times, we could do this test to know what is the origin, to be more successful with the need to do donation in the future, or perhaps an sperm donation. The PGTA is the key for obtain a successful pregnancy. Under 37 years old, we use the selection of non-invasive tests. We do not invasive tests to select the best embryo. It's again for the same. We have really good chances for one attempt under 35 years old without PGTA. We have 65% per one attempt, but if we use embrace, we are more secure that we transfer and we do obtain pregnancy in the first attempt.
Okay, perfect. I'm going to ask another question to all of you, and please keep it really brief because it is like a sort of yes or no type answer. I think there's I'm going to call it confusion, but I'm not sure that's the right word. I think people have become a little bit obsessed with, and I'm talking about practitioners, not just patients, with you have to have multiple embryos to do PGT-A because you have to select. And obviously that is one of the good things about it. You know, I've got multiple embryos, I select the euploid embryo and the other ones I don't select. But do any of you do PGT-A when there's only a single embryo? And I'm not talking about a 43-year-old necessarily, just if there's a single embryo, do you still see a benefit? Because I can see a benefit. It's just a different benefit. So, Dr. Checa, would you consider it?
It depends on the age of the woman. If only have one embryo, normally I try to do banking of embryos.
Okay.
Because if my rate, if I could find, for example, 30% of euploid, I prefer to have 3 embryos because I choose one to transfer finally. No, normally I try to do this policy in my patients.
Okay, but banking is, I know it's a different strategy, but to me, it's still saying one embryo deserves to be tested. Do you see what I mean? It's just one embryo multiple times on multiple occasions. It's just, I suppose I'm saying the opposite is when people say, oh, there's only one embryo, just transfer it. You know, and it's like, oh, well, you might have a miscarriage then. You know, that's the price you pay.
And you lose 3 months or more.
Yeah. Dr. Santos, would you do PGT-A on a single embryo?
If the patient agrees, yes. I think it's the best way to have a diagnosis. But normally, patients prefer to do the transfer if they only have one embryo. It's more often the case. But I suggest to do PGT-A.
And that's somewhat psychological, I guess, right? It's like, don't spend this money, don't do this technique, just transfer it. Yes. Okay. Dr. Fodina, what would you say about that?
Thank you for possibility to including to your discussion. So I want to maybe say the first of all about the first questions what you are discussing before about the lady who had the 3 embryos, which is unemployed, and what to do with that. What I can say from my praxis, usually, if the embryos have tested in some research laboratory, the colleagues get the answer as a yes or no, so aneuploid or euploid. But in the most of the case, especially for the woman or of the 40, if to check these embryos more clear, we have a mosaic embryos. And what is important to not to put these embryos to the rubbish. So to be clear what kind of mosaicism we have. And of course, the reproductologist cannot do that by self. We needed the help of the clinical geneticist who can give for us the answer. Do these embryos can give the wrong baby development, or we have a small chances or decreasing of the implantation or small risk of the miscarriages. That's why it might be very, very careful when we speak what is it, aneuploid embryos, aneuploid or mosaic. If to speak about the second questions about what to do with the 1 embryos, I totally agree to my Spanish colleague. I will be banking these embryos and I will be getting the new portion of the embryos and anyway to checking these embryos before when I will be transferred. Because it is highest chances to get the pregnancy, highest chances to get the healthy baby.
Okay. Thank you. And did you answer the question about the 1 embryo?
Yes, I answered.
Yeah,
so
yeah.
I will be banking.
Sorry, so there was you started with the other one. So that's, and I was checking through the things, and I also saw another question. Somebody's actually specifically asked about 1 embryo, so I'm gonna complete that one. Okay. So right, I'm 42 years old and currently undergoing 2nd round of IVF. During my first, I had 2 blastocysts, both of which showed monosomy PGT-A. At the moment, I have 4 follicles. I plan to do a 3rd round to collect more blastocysts, so embryo banking. What are my chances of proceeding to transfer? Okay, keep it brief, please, Dr. Fodina.
First of all, questions about the quality of the egg. 42 years we are discussing these options. So what I will be doing, I will be examining this patient deeply for the hormonal status, of course, excluded the hypothyroidism, the hyperprolactinemia, hypotestosteronemia. This is the first one. The second one, we needed to excluding one more factors which can affect it for the quality of the egg. It is anti-ovarial antibodies. The third one, we needed to be sure about the amount of the egg, of course, and by that we can doing the suggestions. Can we get it what kind of chances to us to get it the more qualitative embryos as well? And we not needed to forget it about the mans. And one of the options what we usually to do when we examine the patient before IVF, because the monosomy can go going from the man part as well. This is a DNS fragmentation test to see what kind of functionality of the sperm have this man. I hope I briefly.
Okay, well, broadly, briefly. Okay, so I'm gonna sort of summarize this question and start with Dr. Santos. So 43-year-old patient. I think we've got the general message, and anybody listening, if you're over 43, most of the doctors here and many doctors who offer PGTA are going to say you probably should do PGTA, right? So let's clear that one up. So we don't need to answer that every time. But this is someone who's saying, should I do a double stimulation to collect the maximum number of eggs possible in a short period of time? And how many rounds of stimulation would you advise for a 43-year-old? AMH 1 nanogram, FSH 9.9, antral follicle count 11.
So I would do double stimulation because it's the fastest way to get a high number of oocytes in this patient. Of course, if there are follicles that can be stimulated in the second round of stimulation. If not, I would try to do a second stimulation later on. But I think it's important to get a high number of oocytes in order to get euploid embryos. It's always the same thing. But I do often recommend double stimulation, yes.
Okay,
because
perfect.
sometimes in the luteal phase stimulation is better. The response is better than in the first stimulation. So I think patients worth to try this dual stimulation in order to have both types of stimulation.
Okay, perfect. And given that the topic tonight is cycles, and this sort of fits into that brief, very briefly, just sort of almost yes or no, Dr. Checa, would you do double stimulation? Do you do that frequently for a particular demographic?
Yeah, we perform, but it depends, like Dr. Santos said, of the moment of the cycle, because sometimes I saw in the luteal phase antral follicles, and we start the stimulation. So not always there is double stimulation. It depends of the cycle, because it depends of the wave of the follicles that you find this month or next month. But probably in a woman with my numbers, in a woman of 43, I need at least 4 of this anti-Mullerian hormone, 4 or 5 cycles to achieve 1 euploid embryo.
Okay, thank you. That's really useful statistic. Really appreciate that. Okay, I'm gonna move on to the next question. Dr. Fodina, 35-year-old lady, husband 37, 3 failed IUIs, 1 failed embryo transfer, which I'm assuming is 1 embryo, grade 3 BC. So that's early blastocyst. What are the chances of successful implantation with? This is a difficult question, obviously, but let's say from your center, 1 embryo at that age, what would you say their chances are? And is there anything they can do to improve the quality of the embryos?
Sorry, Alan, could you show the questions, please?
Oh, sorry, yeah. It doesn't show all of it, unfortunately, so you only get to see the first bit. And if you look in the Q&A, which is the box on the right hand side at the top, you'll be able to see it.
So the very, very easy answer. The woman, 35 years old, the chances to get the good qualitative embryos from one embryo to 5 oocytes, or 5 good oocytes, 1 euploid embryo. Unfortunately, this lady didn't succeed on the first time, but it's not mean that she will be not succeed the second time. So I will be give for her the pretty high chances to get the pregnancy next time, over of the 50%.
Okay, thank you. Dr. Santos, what we've talked about, I think in all of our answers so far, we've had a lot about preparation and checking and stuff, so let's not do that again. But lady of 38, she's just about to do her first IVF. What can she do in terms of vitamins and supplements and diet to increase her chances, please?
Oh, that's not a difficult question. I would say that if the checkup is okay, I mean, if thyroid function is okay, if vitamin D, prolactin, or the hormonal levels are okay, I would just recommend folic acid and a health diet.
Okay. Anybody have any different opinions on supplements? Because there's a lot of supplements available today, aren't there, for sale?
Yeah. Probably diet, probably not sure. Diet is demonstrated that it's better than supplements. So Mediterranean diet is demonstrated that it enhances the chances of pregnancy. So the recommendation, if you use acid folic, you try to suppress your thyroid if you not have antibodies, or you could do vitamin D if your levels are below 30. But diet for sure is the best way to try to increase all the conditions of pregnancy. Mediterranean diet, like try to vegetables, seeds, fruits. Try to eat white meat, two legs, not 4 legs, without soft drinks, not a lot of coffee, not alcohol, no tobacco. Probably this is the best way that all the woman could help herself, more than try to eat a lot of vitamins or supplements, coenzyme Q10 or ubiquinol, etc. It's going to be the best way for all the women.
I mean, I don't see as many patients as you guys do every day, but my sense is that, particularly with men, that there's a chance that they get obsessed about, a supplement's going to fix everything, and they essentially overdose on the supplement, which could even be harmful, right? So I'm going to ask Dr. Fodina, would you be prepared to put your neck out and say, be careful with supplements? Don't take them, but just certainly don't change the dosage on them.
First of all, thank you for my colleague's answer. So I agree to this recommendation, what they did for the patients, but the one extra things what I recommend for my patient to be careful with the milk protein. Of course, a lot of studies now about the effect for the corticosteroid synthesis and the oocyte quality of this protein. This is a small extra things, but of course, when we recommended the supplements, we needed to be careful because the patient cannot eat 20 tablets a day. Sometimes it's happened, they already come with a package of the different supplements. For my opinion, very important as a woman who planned the pregnancy to get it enough folic acid, or methylfolate, what we usually recommended for patients. And one of important supplements is also inositol, because this is affected for the cells regenerations and help to us during the stimulation time. And one more details. A lot of people now have the unfortunately the overweight, and the correction of these questions very helpful for the getting of the qualitative eggs in the different age. That's why if the people have the overweight before IVF cycles, we needed to compensate that and regulate these questions too.
Thank you. Perfect. I'm not sure I really understand this question, and maybe I'm just being dumb. Which might make it hard for you to answer, Dr. Santos. How important is the laboratory in the clinic? So I guess the IVF laboratory, when we speak about recurrent implantation failure.
The IVF, yes, laboratory is fundamental for the success of IVF, of course. If you have a good lab, you have the higher chances of pregnancy. For recurrent implantation failure, I don't think that the lab will affect the rate of implantation, but in fact it can be determined in the quality of the embryos, the blastocysts that you get. So it is very important to check your results, and we do it each week to see if your fertilization rates and the blastocyst rates are consistent with your practice, in order to try to check if everything is okay or you have to correct anything. So the lab is the most important part of the IVF treatment for me.
Thank you. That was nice to hear from a former lab person. I suppose, having worked in the lab, I would say exactly what you said, sort of echoing it, but focusing on one bit. We used to look at particular indicators, key performance indicators in the lab. And you're right, it's things like, did it fertilize? Did it grow to a certain stage of an embryo? But we often, of course, we looked at pregnancy rate, but for me, implantation rate was a very good indicator of how well the lab was doing. So actually that does really link to recurrent implantation failure in a sense. But I take your point. It's important for every single indication for IVF because it's the engine room of the clinic, right? So I hope that's answered the question anyway. Thank you for that answer. This is a tricky one because this is really long. And all I'm going to do before I read it out is I'm going to ask the person who's written the question to just put in the chat or put in the question, because otherwise I have to flick between. Did you have a karyotype done on you or your husband or both? Because that one just jumped out at me. Okay, a thing that is missing from the information. So this is the question: how many cycles do you think we need? We've had 5 failed natural pregnancies, 2 failed embryo transfers with egg donation, and 1 failed pregnancy with egg donation using the same donor. Do you think we should move to double donation? So obviously the patient's thinking about a sperm donor, so maybe something's wrong with the sperm. And to Dr. Checa's point earlier, you've got to, or maybe it was Dr. Fodina's, you've got to consider both at certain times, even though aneuploidy is most commonly a female or maternal issue. So 5 naturally conceived pregnancies without IVF between the ages of 41 and 45, all of which failed. Both of them are healthy patients. Heart stopped beating between weeks 8 and 10 in the first 3. Did genetic testing of the embryo learned it had trisomy 15, which, by the way, is quite common in a failed, in an early miscarriage. So that's not in itself unusual. The 4th pregnancy was biochemical, and the 5th, the embryo had trisomy 21. So that's 2 trisomies now. During those 5 years, they were encouraged to go on with natural pregnancies, even though, don't forget, I'm just going back to the early bit, that's age 45. Remember all the other stuff we talked about today. And heterozygous for a thrombophilia variant, but we already talked about that. Sorry, I'm just scrolling through. There's a lot in this question. So then they went to do egg donor. Ended up with 4 blastocysts. Doctor said don't do PGT testing because they're from a young donor. I get that. First 2 transfers failed, and the last one resulted in a pregnancy with a blighted ovum and a complete miscarriage at home. Lady's now 49. So I asked the question, should they have a karyotype if they haven't already had it? But should they move to double donation? So I'm going to start with Dr. Fodina, and then we're going to go around to everyone.
Okay.
This is super interesting.
Yeah, of course. If I will see the patients who have several times the pregnancy stopping and several in the second trimester, and when it was recognized some genetic disturbing, the first step what we needed to do, the karyotyping of the both of the patients, because with the big probability we will be found in the Robinson translocation, or from the woman or from the man. And depend of what we have found it, we will be doing the next tactic, what is better to do. And special, how I understand, if it's a very long letters, what we try to read, if the egg donation was provided with the husband's sperm, so of course the absolutely logical to doing the karyotyping of this man, and after that to solve this problem depend of the results.
Thank you. Any other from the other doctors? Do you have any different opinion or different thing that could be done here? So the obvious thing to me, it was obvious to do a karyotype, and the only reason I pointed it out was because I didn't want to make an assumption. There was so much in the question that I assumed if they'd had a karyotype, it would be written down. But for me, that's like a massive red flag. And we had a question in a different session where it was something similar, and I said, "Have you had a karyotype?" And they were like, "A carrier what?" And it was like the alarm bells were ringing. So what do you guys think? So starting with Dr. Checa, and then we'll move to Dr. Santos.
Yes, I think we always do a karyotype before PGTA, so I think it's mandatory to do it.
Okay.
If they haven't done it, it should be done, and then after, if there is, of course, a chromosomic abnormality, we'll try to advise according to that abnormality. If there is nothing in the karyotypes, nothing abnormal, I would go for double donation.
Okay, and by the way, it's a lot, as you all know, but I'm saying it for the audience, doing a karyotype is a lot cheaper and quicker and easier than doing another donation cycle. Dr. Checa, do you have anything to add, please?
For sure, completely agree. Yeah, we perform karyotype in all our patients, and probably these particular patients skip for our scope of reproductologists, because probably all these failures that did happen, it's more in advanced weeks and probably related for all of these kind of problems that sometimes we start the treatments. No, here I think it's the space for the immunology. Here's the space for the thrombophilias. Here's the space from all the complications related with the pregnancy, more than to obtain the pregnancy, because this woman achieved many pregnancies, and probably the problem it's behind this our first part that we developed.
Okay, thank you.
In our case, we work with an immunologist and with a hematologist that try to cover all of this part, and they do supplementations with several treatments for these patients that are out of my scope completely.
Okay. Thank you. Appreciate that. And I appreciate all the transparency and honesty from all of our doctors today. It's been great. Particularly when you earlier, at least one of you said, if I have a patient this age, I pretty much say, we're not doing IVF with your own eggs. And I love that kind of honesty, because that isn't my experience of every doctor. And I know we can always say, oh, I do what the patient asked me to, they want to do this, but I like you sticking to your principles. So we're on to the final question, and then I'll do a little roundup and see if you have any last things you want to say. And then we'll have done our hour, which is nice, because I know some of the doctors need to leave because they've got busy clinics tomorrow. So we'll start with Dr. Checa, then we'll go to Dr. Santos, and then we'll go to Dr. Fodina. So this question is a 47-year-old patient doing IVF with a fresh donor embryo from fresh donor eggs from a 22-year-old donor. The male is 49. It says, is it possible? But I'm going to change it to, should they do sperm aneuploidy testing for the male versus doing PGTA because they're worried about damaging the blastocyst during biopsy? So I think we said Dr. Checa first. So I want you to address, do you think there's any value in doing sperm aneuploidy testing? And obviously it's reasonable to worry about damaging a blastocyst. That's a reasonable concern. And I know you do non-invasive. I already heard that. But how would you counsel a patient who was worried about blastocyst damage? So sperm aneuploidy and blastocyst damage.
Yeah, we don't test sperm antibodies. We don't check because there's not evidence that this affects our pregnancy chances.
Wait, just be clear. You said antibodies, aneuploidy. You know, the fish test.
Sorry.
That's okay. That's okay.
Yeah, we do DNA fragmentation because we have a recent publication with 3,300 donations with sperm aneuploidy, and the rates of pregnancy was with aneuploidy or without aneuploidy exactly the same, with 300 donors. Okay. But talking about PGTA, the same as I recommend to all my patients over 37 to a PGTA in a donor with 22 years old, we don't recommend PGTA, okay? Because there are many studies that show that our pregnancy chances are the same under 37 without or with PGTA. About the chances of pregnancy with a donor of 22 and a sperm of 49. The chances of pregnancy that we have, clinical pregnancy that we have in egg donation in our program with one attempt only is 79%. So this is that we expect in our clinic for the chances of this first attempt of this couple.
Perfect. Dr. Santos, same question, and if you've got something different, that's really helpful.
Yes, briefly. I was the first one to publish fish in sperm in the early 90s, but we don't perform it anymore because it's not useful at all. In fact, it's nothing useful to know that 50% of the sperm cells are aneuploid because you can't select them to use. So even if it's interesting as a research tool, we don't use it for clinic purposes.
Thank you. That's really honest. Like you're one of the pioneers of doing it, as was I. I would add to that. When I was working at iGenomics, we didn't do that many, but of the ones we did, I don't ever remember a result of 50% aneuploidy. So even, you know what I mean? Even if it was that high and you said, well, I can't do anything about it, I never saw it that high. So it never looked like it was that much of a risk. Dr. Fodina.
So I totally agree to my colleagues from Portugal, professors. So because we're not doing this examination anymore for our patients as well, because if we are checking the cost effectiveness for this PGTA and fish method, first of all, both of them, it is expensive for the patients, but the results, what we can getting after the PGTA, more important and more increase the succeed of the embryo transfer as a fish before. So we are not provide anymore this method for our patients.
Perfect.
And with one more details, I understand about what the patient stressing because probably the patient read it about the novel mutation, what might to be compared with the age of the man. Of course, we are not so good in these questions now, and we don't have the method what we can using briefly in the genetic laboratory as to found the novel mutation. But the percentage of the novel mutation and population, it's calculate very clear. 1 to 100,000. So this percentage very low. That's why the PGTA probably will be the main benefit for these patients.
Okay, thank you. That's really helpful, and you've introduced, I think, a new concept to that question, because at least it's not written there saying I'm concerned about the age of the man in terms of de novo mutations, i.e., new potential problems for the baby. What I would say to the patient there is have a genetic counselling session and just talk about what are the risks for an older man, because it will be a very reasoned conversation. It won't be something to scare you. It will just be, there are slightly higher risks, but it's just good to know about them, but it's nothing to particularly worry about. So let's close off the session by just going around each of the doctors and just saying, what's your takeaway message you want to give to patients about numbers of cycles. Just keep it short and sweet, because it is complicated. So let's start with you, Dr. Fodina, and then we'll just go around, and then I'll close off the session because I know you need to leave soon.
So this is the most difficult part of our discussion, because the message couldn't be message for all the patients. But anyway, I want to say that if you are getting the negative results in previous treatment, you not needed to maybe stop to hope for the positive results in the future. You needed to find a specialist who will be sitting together with you and going detailedly through your history, because how you understand, we don't have any recipe or the answer for all questions by 2 or 3 sentences. Each cases, it's very individual. But from other hands, we needed to remember the reproductive age, unfortunately, limited. We cannot do the wrong things together with you. We must to stopping some of the patient, unfortunately, if the age is over of the limit. So, and please will be all of you healthy. And I also want to say to you, I want if all the patients who didn't succeed before, in the end, getting the results and baby to home. It was very nice to be with you. Thank you for the attention.
And thank you for your contribution. Thank you. Dr. Checa, what would you like to, give to the patients for the last, very brief sort of summary?
Yes, probably the best counseling for the patients from the major amount of patients that are consulting to us today, there's patients over 40 years old, is try to select very well how do you perform your IVF. Because performing IVF in a woman under 35 years old, it's super easy. It's super easy staying a pregnancy, and probably good or not good labs could achieve a pregnancy. But when you are trying to achieve a pregnancy over 40 years old, you need to see all the details, because sometimes it's not a huge increment of the percentage of pregnancy. But if you are taking 1% from the stimulation, another 2% of the culture, another of the insurance of all the environment of the patient, it's in the good way. Finally, you achieve, perhaps there are not more, at 40 pregnancies more a year, okay? But this 41 going to be very happy. So in this kind of woman, you could not industrialize the fertility. You need to go patient by patient, because it's very important. It's very important because if, for example, they have a lot of eggs, you could do one strategy, and if she has that egg, another strategy. But the message is that if finally you could find euploid embryos, there are very high rate of success that you have a successful pregnancy. This need to be the message. If you don't find euploid embryos, probably the best message is try to change to another way. Normally, it's not the way that we choose, but it's the way that you have a family. So this is the message for attempts. So the rate that we have with PGTA, with euploid embryos, it's we have 75% under 35 years old, but 71 in 40 years old. The difference is it's very, very, very similar. So try to find this good embryo in a clinic that have a good culture and with a clinician that could go 360 around you.
Okay, thank you. And finally, Dr. Santos, what would be your take-home messages for patients?
When there is a situation like this, I will usually go back to the beginning and start looking at everything that has been done and every detail, and try to explain to the patient or the couple the meaning of each cycle and each success or insuccess. After that, I think it's a couple's or a patient's decision, because as Dr. Checa was saying, if there are euploid embryos, I would recommend to try to another time and maybe another time, because we know that the embryo and the endometrium are the two key factors for the implantation and successful pregnancy. So as soon as they have euploid embryos, and they are able to continue, I would continue checking everything from the beginning. If there are no implanted embryos, I would go for other types of families and donation.
Okay, perfect. Well, thank you all so much. That's been really helpful. I really hope that's been useful for our audience, our patients listening in. The final thing I'd like to say is, if you want to follow up with any of the doctors at those clinics, of course you don't have to, you can go anywhere, but you probably feel you know them a little bit better now, so please feel free to contact them, and you can either contact them directly or you can do it through My IVF Answers. If you want to speak to me about anything, I'm independent. I'm not working in a clinic, so you might want to just pass things by me. Feel free to do that. My details are available on the My IVF Answers website as well. So it only leaves me to thank you all for attending, and thank you for the doctors for doing such an excellent job of answering this, this tricky topic. So thanks very much, and hopefully see you all again soon. Bye for now.
Thank you.
Right, thank you very much.
Bye-bye.